Well, good morning. Good morning. Hello, everyone. Hello, and welcome to today's online event on turning strategy into reality. Clinical audit as a strategic enabler of the NHS 3 shifts. The first session in this year's Clinical Audit Awareness Week, run by HQIP, the Healthcare Quality Improvement Partnership. I'm Ian Smith. I'm an Associate Director here at HQIP, working with our Chief Executive on developing our plans for a new association for clinical audit and registries. More on that later in the session. And I am your host for today's event. Firstly, please note that this event is being recorded and we aim to make both the slides and the recording available on HQIP's website. Also happening throughout Clinical Audit Awareness Week are the Excellence in Clinical Audit Awards. These recognise individuals and teams who are transforming healthcare through clinical audit and evidence-informed improvement projects. And on today's schedule, we have a lunchtime session at 12:45, 1:45, which will announce the winners of the Strategic Impact category. You can register to join that session via the Clinical Audit Awareness Week page on HQIP's website, or the link shown on the top of the slide on the screen. So throughout the week, we have a packed programme of sessions across 5 themed days. Again, more on those later in the session. Today's session looks at turning strategy into reality and the critical role that clinical audit can play to realise the ambitions set out in the 10-year plan and other key strategies. So I'd like to welcome our speakers today, Professor Sally Lewis and Dr. Sunil Nedingayal. Really great to have you with us today, and full introductions for both coming soon. But first, if we could move to the next slide, please. So before we start, a few notes on housekeeping. All of the microphones are automatically muted to avoid any background noise. Cameras are on. Please feel to keep them on or switch them off if you prefer. The chat function has been disabled today for this event, but you can use the Q&A, the question and answer function, to put your questions to the speakers. We do aim to have some Q&A at the end of each speaker's presentation. To submit a question, select the Q&A button, which should be on the top of your screen. And again, if we're tight for time, we will collate all of the questions to share the Q&A after the event. We have been advised by Microsoft, no less, that it's best to use a laptop or PC rather than a phone, and the browser version of Teams rather than the app, to get the full Teams webinar experience. So if you do have any problems accessing the Q&A, please do try switching to the browser version. And if you're unable to access the Q&A and you have a question, you can still do this by sharing it with us via the Contact Us form on our website. And again, should we experience any technical issues, fingers crossed that we don't, we're hoping not to, but if we do and the webinar ends earlier than expected, please wait around 30 seconds or so, and then you should be able to rejoin by clicking either the rejoin button on your screen or via the original joining link that you've entered with this morning. And finally, we encourage everyone to share on social media about this event and any activities that you may be running in your organisations up and down the country during Clinical Audit Awareness Week. If you can use the hashtag CAAW26, hashtag CAAW26, that will help us to connect around the event. Now, let's introduce our first speaker, so if we can move to the next slide. So first up, we have Professor Sally Lewis. Sally is the founder of Kintsugi International. She's a leader and author in the field of value-based healthcare. Sally's career spans over 30 years as a general practitioner, medical leader and policy advisor, and she's dedicated her career to transforming healthcare systems worldwide. Sally's now an international advisor on value-based healthcare systems transformation, as well as Professor of Value and Health Management at Swansea University's Value-Based Health and Care Academy. I hope I said that more or less right, Sally. So Sally's work's been recognised by many institutions, including Harvard Business School and the OECD, and she has just published her first book, Implementing Value-Based Healthcare, an Insider's Guide to Improving Patient Outcomes and Creating Sustainable Systems. So if we can move to the next slide, and Sally, over to you.
Thank you, Ian, and thank you for inviting me. It's lovely to see so many people on the call. So I suppose I want to begin by throwing in a bit of a provocation, because the 3 shifts that we see in the 10-year plan are not particularly new, particularly the fabled left shift from hospital to community and to a more preventive medicine agenda. And I want to show, if I can, the critical importance of clinical audit and its relationship to value in health, and how we need to maybe elevate clinical audit from how it may traditionally have been seen in the healthcare system as a quality improvement tool for clinical teams, important though that is, to something that is really influencing policy and broader decision making across the NHS. Next slide, please. So, quick recap. Value-based healthcare has been defined in a number of ways by a number of commentators, but this definition from the Centre for Evidence-Based Medicine in Oxford probably brings all of those definitions together. And it is the equitable, sustainable and transparent use of available resources to achieve better outcomes and experiences for every person. And the word outcome is key here, and you'll start to see how important clinical audit becomes to this agenda. And value-based healthcare sits on the back of many other professional movements around the world that are focused on similar parts of this agenda. So slow medicine in Italy, a real focus on preventive care, realistic medicine in Scotland and prudent healthcare in Wales, looking at unwarranted variation, co-production with our patients, and doing only what is needed and doing no harm. And Choosing Wisely International, of course, which was focused on reducing low-value care. Next slide, please. The problem is systems, health systems in particular, can make doing the right thing incredibly difficult. Now, if you think about the three shifts that have been described, as I said earlier, we know about these three shifts and have known about these shifts for a long time. And I confess, I did a little bit of an eye roll when I read the 10-year plan, because I thought, what's going to be different this time? In all the years of my career in general practice, I have not witnessed this left shift into the community. So why is that? And basically, there are so many drivers in the system that are creating different decision-making behaviour that it makes these left shifts very, very difficult. And I'm going to show today why clinical audit is critical to driving forward these changes that have been so difficult to achieve in the past. Next slide. So our decisions and our behaviours are driven by many external factors. This gentleman is B.H. Skinner. He was a very famous behavioural scientist from the 20th century, and he is famous for this set of experiments with some rather unfortunate rats, I have to say. This is Skinner's box. And what Skinner proposed was that we're not actually as in control of our decision-making behaviour as we think, and that our extrinsic motivations are far more powerful than our intrinsic motivations. So Skinner's box, you see a rat in a box, and the rat quickly realizes that if it pushes one lever, it's going to get food. And of course, it keeps pushing the lever to get the food, and that's positive reinforcement. And then the other thing that Skinner did, which wasn't very nice, was put a mild electric current through the floor of the box. Didn't drastically hurt the rat, but it was unpleasant for the rat. So the rat quickly figures out there's another lever in the box which turns off the current and makes his life much nicer. That's negative reinforcement. And we use negative reinforcement quite a lot in healthcare to get people to do things. Usually, we need you to hit a target, and we're going to shout at you if you don't hit that target or something else. You get the idea. That's negative reinforcement. And so, of course, we focus on targets. And in our system, that's very much about time-based metrics, waiting times for outpatients, ambulances queuing outside, EDs. And so we try to tackle those problems in a way that doesn't really address the root cause of the problem. And this impact on our decision making based on that negative reinforcement within the system makes it pretty impossible for us to make the decisions we really want to do around left shift and preventive medicine. and particularly around resource allocation for those things. Next slide, please. So moving on from Skinner and his rats, what creates behaviour change for us, therefore, in the system? And I would argue that there are a few things that we can do to really influence this. The first is data transparency. There is absolutely no doubt that data transparency changes behaviour. I know this firsthand as a GP, having been presented with my prescribing behaviour and my referral behaviour for years. Nobody wants to be an outlier. So you look at your data, you come back into the pack, and we start to reduce variation. But here's the thing. We don't know if that variation is unwarranted unless we understand the outcomes that our patients are achieving or not achieving. So creating transparency around data, and particularly around outcome data and what things cost in the system, is critical for achieving value in health and the 3 shifts. And it will create discomfort, as for the rat, and we will do something about it. We are not transparent over data, particularly. I think we're getting better. Clinical audit, of course, is a real way into that, and we need to make it, in my view, even more transparent, and to give it parity of esteem, shall we say, alongside the other traditional metrics that we have in the system, so that decision making is much more balanced and not just about financial targets or time-based metrics. And of course, absolutely alongside that comes clinical leadership, and the need to be able to interpret and act on that data credibly. And clinical audit absolutely joins those 2 aspects together of clinical leadership and transparency. And then alongside that, we need stewardship and possibly some incentives. Really interesting to see what happened when the Quality and Outcomes Framework was introduced to general practice in 2003. There were incentives for doing better chronic disease management, mostly around hitting process measures and clinical indicators, but it changed everybody's behaviour very quickly within 6 months. So we need to think about that too. Next slide, please, Ian. So what do we mean by outcomes, and how may we use that data? Well, outcome is a funny word. It's used interchangeably to mean lots of different things in healthcare. But here we're talking about outcomes that matter to patients, outcomes that matter to people. And here's an example of a standard set of outcome measures brought together by ICHOM, the International Consortium for Healthcare Outcomes Measurement. And ICHOM have a pretty robust methodology on bringing clinicians and patients together around what matters, and then selecting the tools to measure the outcomes that matter to people. So you'll see instantly that quite a lot of these things are covered off within clinical audit already. So things like for diabetes, I think we've moved a slide on, yeah. Thank you. Things like for diabetes, looking at glycemic control, treatment complications, end organ damage, those sorts of things, and acute events, so acute adverse events. These things are captured in audit, but we don't necessarily put those data alongside healthcare utilisation, and critically, the cost of healthcare utilisation as a result of those things. So triangulating this data with other data points in the system helps us understand what we need to change to avoid badness, shall I say, in the system, and to achieve better outcomes, and where we need to invest, and specifically how we need to invest. So, for example, in diabetes, checking in on whether we have properly supported self-management for people in the community to manage their diabetes. And that's why ICHOM add in also patient-reported outcomes, because it gives us a lot more information about patient need and symptom burden in the community. So in this instance, in diabetes, the diabetes distress PROM really gives you a feel for how confident patients are in managing their diabetes and how distressed they are by their disease, and therefore how likely they are to be able to carry out the self-management necessary to get better outcomes in partnership with their clinical team. Now, we don't have that as a widespread metric at the moment, not even in clinical audit, but that's okay. We can start with what we have and move on from there. Thanks, Ian. Next slide. So how might we collect some of this data in a more efficient way, shall we say? And as we move to a more digitized environment in healthcare, it becomes a lot easier, of course, to obtain information, especially data from patients, which may have been quite difficult to obtain in the past. And then we can see that the patient outcome is not just the consequence of their illness or a treatment which we might give them, it's also a milestone. So then either in episodic care, like, shall we say, a cataract pathway or any other surgical pathway, or in a chronic disease like tracking heart failure, shall we say, or COPD, we can use that outcome data to support shared decision making with patients around what their likely outcome is going to be if they choose this decision or that option, and also as a symptom tracker. So, for example, the Cancers Cardiomyopathy questionnaire is really useful for tracking disease-specific symptom burden in heart failure. And that we found can lead to triggers for key conversations like when to switch into palliative care from perhaps more aggressive management of the disease. So it's a useful tool for care, is what I'm trying to get across. And if you have a tool such as a patient-reported outcome that is useful and meaningful for patients and their clinicians, alongside blood tests and scans and everything else, we're going to get a much more robust data set for secondary purposes later. So that's just a little bit around PROMs alongside clinical audit. But of course, what we're really trying to do is get outcome data and other real-world information, such as costing data, put together to guide our decision making at every level of the system. So that might be whether we continue to pay for a very high cost drug post adoption. Is it really giving us the outcomes that it purported to do in the beginning? Or it might be, gosh, we can see this need from our clinical outcome data in the community, and we see that we need to do something differently to meet the needs of these patients in the community. So outcome data has not been used, I would argue, and clinical audit hasn't necessarily been used alongside other policy statements to drive these three shifts in care. And my provocation is, let's do that. Next slide, please. So just to hammer that home with a story, the story is from Wales. Everywhere across the UK and indeed in many places in the world, a problem in urgent care presents itself as ambulances queuing outside the emergency department, corridor care, and, you know, basically real pressure at the front door. And we need to make the link, I feel, between clinical audit and real world problems that are reported in this way. You know, waiting list times could be another problem that is presented as a waiting problem. But actually that waiting problem is essentially failure demand. So it is a system created problem because we are not meeting people's needs in some other way, in some other place. So triangulating data and boundary spanning collaboration are critical interventions. And in Wales, what we saw, and I'm sure this is very similar in the rest of the UK, that the top 3 reasons for conveyance by ambulance to ED were breathlessness, falls, and palliative care. So when looking at investing in solving this problem, policy leads were not really looking at who was coming to ED. They were just trying to tackle flow and to get everybody to move faster, offloading times being imposed at the front door, measuring 4-hour waits in the ED and this type of thing. Whereas sitting over in another part of the system, the palliative care consultants were busy collating data on outcomes and acute healthcare utilisation of people in their last year of life. And we have this last year of life population dashboard. And unsurprisingly, I suppose, what it showed was that we were not very good at identifying people with non-malignant disease in their last year of life. We were not providing adequate end-of-life care in the community for these patients, and they were needing to come as emergencies to hospital, often multiple times, and often conveyed by ambulance in their last year of life. So it's really not rocket science, but if we start to put these different data sets together, and I'm sure you can think of many other examples, we can start to really inform policy and resource allocation around how we tackle these issues at their root and really focus on meeting patient need rather than putting sticking plasters on a struggling system and everything that comes with that, including huge pressure on staff. Next slide, please. So this basically requires a whole pathway approach, of course, and I really like this image because it doesn't describe any services or professional group on it. It's really about doing a forensic analysis at each step based on outcome and resource allocation data to see where we're falling down at meeting patient need and then what impact that is having at a system level. So we need to get away from just looking at episodes of care to looking at the whole journey, the whole pathway, and moving away from just thinking about our service response to how the system needs to respond in a very patient-focused way. We know this, we say these words. I believe that clinical audit presented in perhaps a slightly different way, triangulated with other data sets. If we put that up in lights, I think we can start to influence different decision making to support these shifts in care. Next slide, please, Ian. So deriving value from data, one of the big lessons for me was as we started to do a lot of data work on value-based healthcare when I was working in Wales in the health service there. Everybody wanted a dashboard. Everybody wanted a dashboard, and we had total dashboarditis. And what we found was that then hardly anybody looks at them for various reasons, unless they are enthusiasts in that particular data set. But from a system perspective, there's lots of different condition-specific and service-specific dashboards. How do we generate observations, insights, and questions and triangulate those different data sets so that we can provide data products for all of these levels of the system? And today we're talking about the 3 shifts, so we're thinking about influencing organizational and policy behavior. So thinking about how can we generate insights from the variation data that we see in clinical audit alongside perhaps some of the other data sets being used to make decisions in the system. I believe that is how we might start to change decisions and achieve the shifts. Next slide, please. So, to conclude, healthcare systems are products of all of our accumulated choices. And my favourite quote from Atul Gawande is, from his book Being Mortal, and he says, life is choices. They are relentless. And so we have to start using the data to improve our choices and create the shifts that have been described in the 10-year plan. And I believe that the data contained within clinical audit is a really good step towards that aim. We just need to really think about how we use it to influence decision making alongside the more traditional metrics that are in the newspapers every day. And I think that's probably my last slide, Ian. Yes, thank you.
Thank you, Sally. Thank you. A great opening, I think, to Clinical Audit Awareness Week. I see that colleagues are putting some virtual applause into the screen there, unprompted by me. Thank you, colleagues, for giving Sally the virtual applause that she deserves. I think we probably do have time for a question or two. I'm not sure if any have popped into the box yet, but if you've got a question for Sally, do get typing into the Q&A. To start us off, I have a question, Sally, if I might put it to you, if you don't object. Let's see how we go with this one. So the current landscape, we've had a bit of a shift. It seems like it's been going on for some time. But we've arrived at a point where we've got a slightly new configuration for integrated care boards, at least within the English NHS. And we've recently had released the new strategic commissioning framework. So they have a role as strategic commissioners. The strategic commissioning framework emphasises them understanding their own local context, developing their population health strategy, using their payment functions to drive improvement and better value and more effective care, and then evaluating the impact. So the question around that is, what role do you see for clinical audit and outcome data within that strategic functioning, strategic commissioning role?
Yes, it's really important, isn't it? And of course, the strategic commissioning framework, which I have read, and you know, it says all the right things, doesn't it?
It does say that, yeah.
It really does say the right things, as does the 10-year plan in many ways. But again, I kind of did a little, ooh, is it going to change anything? I think that again, clinical audit, and we need to kind of think about what is the data, what's the outcome data that we can extract from clinical audit in a specific way to answer some of the questions that commissioners will be asking, and understand how we need to link that to other data. So I think it serves both as a needs assessment, obviously, but also then a commissioning tool. So data transparency, as I said earlier, is one way into this. And then there is, you know, the question about whether they are going to start commissioning properly for outcomes rather than activity. So we absolutely get what we pay for. So activity-based funding, if you fund somebody for an appointment or a procedure, you will get more appointments and procedures. Of course, you know, back to Skinner's poor rat. You know, you're going to fund the you know, what you're going to be rewarded with. So there are unintended consequences, of course, sometimes about incentivizing payments for outcomes, and we need to be mindful of that. But I think data transparency and bringing outcomes into the commissioning process will be essential to achieve these aims.
Thank you, sir. That's a really thought-provoking response, and it sounds to me like there could be a role for clinical audit and outcomes data across all of the 4 stages of that strategic commissioning cycle. So certainly a role here, an opportunity to do, as you suggest, and try and kind of amplify our kind of collective community voice around the role. I think that maybe audit and outcomes data could play in commissioning, while it's very much a hot topic. Just going to pause briefly and ask Lacey, do we have any burning questions in the Q&A box to put to Sally before we get to our next speaker?
We do. We have multiple
Excellent.
questions flying in now. So
I think
I'm going to start with, I mean, I think actually you may have to deal with some of these after this event, but I'll start with the first question, which is from Sarah Chessel, which is really around the evolving pressures within health and care, and how do you feel an acute community provider can shift more effectively to utilise outcome data and clinical audit to enable patient-centred approaches?
Yeah, great question. So I think, look, last year I was on a ministerial advisory group in Wales looking at performance and productivity of the Welsh NHS, and went round a number of acute providers, all of them actually in Wales. And what struck me was we're just trying to make a very tired group of people just work harder and just having a focus on flow. And of course, good flow and efficiency is important, but it just isn't going to solve the reasons for the pressure on the system by itself. So using the outcome data as a needs assessment, exactly as we saw with the palliative care, urgent care space, finding out then what we are missing in the community, and then designing services around that and figuring out how to fund that, perhaps through the strategic commissioning framework that Ian mentioned just now, is a way into these problems. Now, I know that's not easy in a very resource constrained environment, and this is why clinical involvement is so important, because that stewardship piece comes into play. Then we need to think about what can we stop doing, or what can we do less of, in order to produce some wriggle room for investment. But these integrated boards, they have a corporate finance function which should have some flexibility around at least starting to do some of this left shift. But unless we use clinical and patient data to inform that, I just think we're going to find it incredibly difficult to do. Excellent question. Thank you.
And a great answer as well, I think. And again, you mentioned the strategic commissioning framework. There's an emphasis in there, sort of a little bit hidden away, but I think the message of commissioners commissioning effective care and care which is effective really comes through a little bit. I think the story that you shared around the ambulance and the palliative care really highlights the difference between where care wasn't effective, and by looking at outcomes and changes, what could be done to make it more effective and more patient-centered. So I think it's really a really powerful story that's a really strong fit with some of the strategic landscape that we're looking at right now. I think reinforced with your answer there. I think, Lacey, maybe have we got one more question that we can take and Sally can answer before we move into the next speaker?
Yes, so with apologies to everyone who's posted questions, I'll just choose one that I'm drawn to, which is from Jeanette Milne. We have more data than ever. Do you see AI as an opportunity or a threat to triangulation of data?
Okay, well, another fab question. My disclaimer is I don't claim to be an expert in AI, but what I would say is I think we need to walk before we can run. I think there are significant gaps in the data, particularly when we're talking about community needs assessment, and we need to be careful that we don't bake in inequalities in health, as you know. I mean, in the future, I'm sure it has a role, but from my perspective, I think we need to get much smarter around how we present and visualize the data that we have, so that people can assimilate this data in a second, rather than feeling that they have to be pointed at and trawling through data dashboards, which many people don't have the time to do. So we need to think about how do we change the data into actionable information. That's just my opinion, so apologies to the AI enthusiasts in the audience who probably know a lot more about it than I do.
Perfect timing. I think if we could give Sally another round of virtual applause, if you could indulge me, I think that'll be a perfect transition into the next. You've got some little love hearts come up there as well. So I think
thanks so much.
Some positive feedback for you, Sally. It was really informative, an excellent start to Clinical Audit Awareness Week, and some really thought-provoking, I think timely and very relevant content there, and somebody I think prompted by some really good questions and some great answers. Thank you very much. Without further ado, we will move on to our next speaker of the day. We have Dr. Sulan Nedun Gayo, He's the Senior Clinical Lead for the Falls and Fragility Fracture Audit Programme. He's also a GP in the Northwest. And before becoming a GP, Sunil trained as an orthopaedic surgeon. He's Clinical Director and General Practitioner with extended role in musculoskeletal medicine at East Lancashire Hospital NHS Trust. Sunil has over 25 years of NHS experience across primary, community and secondary care, and he's served as the Medical Director for the Northern Health Science Alliance and as a member of, deep breath for this one, the NHS England Best MSK Health Osteoporosis Falls and Fragility Fracture Working Group. He's also a clinical advisor to the Royal Osteoporosis Society, a GP educator and appraiser, and an honorary clinical senior lecturer. Sunil's expertise centres on holistic patient management, quality improvement and bone health, and he's pioneered national and local initiatives to enhance osteoporosis detection and fragility fracture management in primary care, contributing to both benchmarking research and clinical innovation. And now, without further ado, Sunil, over to you, sir.
Thank you, Ian, and good morning to everyone attending this webinar. I hope you can hear me all right. Well, from what Sally has said, I carry on probably giving you an oversight into how a particular clinical audit program can help drive patient improvements. Next slide, please. And what I will talk you through for people who are unfamiliar with the particular audit program, which is the Falls and Fragility Fracture Audit Program, I'll take you through a few of the basics and how we support the healthcare quality improvement and probably discuss a bit on how it ties in with the 3 shifts. Next slide, please. So for those uninitiated, the Falls and Fragility Fracture Program is a suite of 3 audit programs kind of following the clinical pathway of fragility fractures. So we have the oldest, which is the National Hip Fracture Database, which audits the care for hip fractures across hospital trusts, and I'll come to that in a minute. We have the Fracture Liaison Service Database that deals with all the other fractures other than the hip fractures and evaluates the care that is provided to the patients. And then we have the National Audit on Inpatient Falls, which until now was auditing or measuring the care provided to people who sustained hip fractures following an inpatient falls. But now the scope is extended a bit wider, and I'll come to that in a second. We're predominantly working in Wales and England, but we also cover Jersey, Northern Ireland, Isle of Man, and Guernsey. And we're commissioned by HQIP and managed by the Royal College of Physicians. Next slide, please. Thank you. So, as I said earlier, it's more of a pathway that we try to work on, and the program itself audits the service provided to people with fragility fracture care, with fragility fracture. And as you can see, the number of people affected by this condition is phenomenal, and we see about 500,000 fractures every year. So besides collecting all the data, the audit program also supports with healthcare improvement initiatives. Next slide, please. So why is fragility fracture important? And as Sally mentioned earlier, it is something that affects the whole health system. And if you were to look at the numbers, this is a couple of years old. The numbers are even larger now. If you look at just the admitted fragility fractures, and if you add up all the people in hospitals with pneumonia and COPD, the admitted fragility fracture comes a very close second. And this is with regard to staying in hospital. But within that, if you look at, when you go through the data a bit more, you see that the fragility fractures cause a lot of, or the cause of delayed discharges in hospitals. And this is one thing that we, earlier on we talked about flow, and that is why fragility fractures are so important, because if we are looking at a pathway, which is the urgent and emergency care pathway, it has an important part to play in the way we audit the care that's provided to these patients. Next slide, please. So I'm just giving you an example of one audit program and what kind of data we hold. So as an audit program, we are probably the largest database on fragility fractures in the world. And the hip fracture database has over 1 million hip fracture records. The Fracture Liaison Service database has about 500,000, if not more, if we add up this year's as well. And the inpatient falls audit program, which is launched fairly recently, has now expanded data collection to spinal and head injuries as well. So we do hold a lot of demographic data, plus hospital level data, and the data is the criteria is based on the care processes that follow people, say in this case with hip fractures while they are in hospital and immediately after discharge. Next slide, please. So what do we do with this data? And this is where how clinical audit influences the behavior comes into play. So a lot of work is done around benchmarking. The ultimate aim is to provide high quality high quality service through healthcare improvement, but benchmarking forms a big part. But by benchmarking alone, I don't think we can make a huge change. We also provide quality improvement support through our webinars and other methods. We have a knowledge exchange process. We also support patients, and through our patient and care panel, we do co-produce a lot of patient resources. As you can see, the lot of data is held in these audit programs, and therefore we do support researchers and others to, for publications. I think one of the ways we influence policy is through our annual reports, which is called the State of Nation report, which comes out every year and points the health authorities, governments into directions where health policy should be directed. And above all this, we also take some time to support sites with quality improvement training and support. Next slide, please. So there are 3 audits. There's a lot of data to go through, and I don't have that time to go through everything. So I thought I'd choose some examples across each of the audit programs to highlight how the data drives improvement. Can we have the next slide, please? So as I said earlier, benchmarking is probably what we do the most, because we want to try and make sure that variation in care is as minimal as possible. And through this process, we identify outliers, both positive and negative. And also through the data and the feedback that we give, it also improves performance and the quality of care. And the changes that can be made are at various levels. You can have it done at local level. You can have it at a system level. And also, it also drives research and quality improvement initiatives, which then turns a full cycle of improvement through the system. Next slide, please. So if you were to go to each of the websites, this is the kind of dashboard that we'll see. Sally did talk about dashboards, and I think having dashboards, and I agree with you, Sally. I think how you interpret what's there in the dashboard is equally important. So these are screenshots from 3 of the dashboards that each of the audit provides, and anyone who has an internet connection can view these. Next slide, please. I'll go into a bit of detail into this. So this is the example of the hip fracture database dashboard. And what you can see is you can get different levels of data. So the granularity goes right down to the hospital level, and it also goes down to each of the key performance indicators as well. So that's one way how we benchmark and make that benchmarking useful for people who want to make those changes. Next slide, please. This is the dashboard that we produce for the fracture liaison service database, where you can see a lot more detail coming in. So that long big arrow on your left is what we call the missed opportunities. So based on all the work that we have done over the years, we have been able to calculate what the expected, shall we say, fragility fracture caseload for a particular area will be. Now, that can be at a national level, and that can be at a regional, or that can even be at a trust level. And then based on what data we collect, we have now identified that gap. So if you look at the first 2 columns, so for example, national averages, 225,000 plus is what you really need to be, seeing as fractures, but what comes into the database is 92,000 plus. So that immediately shows a gap and where we need to focus our energies. Similarly, you can compare various benchmarks, you can compare yourself to peers, and you can, as regions or integrated care systems, look at how you are performing and what your gaps in your service provision is. And when I say gaps in service provision, it also means the gap in the care that patients receive or don't receive. So this is how you need to be using the data to make the changes in the systems that that you work in. Next slide, please. So I'll give you another few examples of a bit more granularity now with the data. So the first one, next slide, please, is an example of how we do secondary prevention in the National Hip Fracture Database as an example. So one click, please. And you will see that this was what was happening to secondary fracture prevention. As you know, secondary fracture prevention is important to prevent further fractures. So in 2021, the average was 29%. And next click, please. As the years went by, you can see every year there's a year-on-year improvement, 34. Next slide, next click, please. 43, and the next one, please. And that's in 2024, the latest figure is 61%. So what you can see here is when there has been an emphasis on focusing on secondary prevention after a hip fracture, due to the work that was done over the years, it has shown that the care for the patient has improved. So at the end of the day, yes, you are measuring a process, but at the end, you're making the real benefit to the patient in preventing future fractures. So this is one example within the National Hip Fracture Database. Can we go to the next slide, please? So this is an example from Wales, where we are using the example of the Fracture Liaison Service database as a measure of patient identification. So again, Wales had identified that their case detection or identifying patients with fractures was not great. They have put in a lot of health improvement measures, and you can see the improvement in the last couple of years. So this is how the data that we provide as a clinical audit can be used for, this is at a more of a service transformation level. So that's yet another example of how patient outcomes are improved. So because the more you identify, the better care follows following that identification. Next slide, please. And with the National Hip Fracture, the National Audit on Inpatient Falls, one of the things we were able to understand running the audit is patients don't just fall and break a hip, they have other injuries as well. So as a quality and safety domain, but also from an equity point of view, we found that we are missing, or patient care in certain aspects is not being addressed. And that's why we have now expanded the National Audit on Inpatient Falls to include all falls related fractures, head and spinal injury. So this is how the feedback from previous data collection plus feedback from the people who actually use the audit helps us drive these changes. Next slide, please. So it's, as I said earlier, it's not just collecting data, benchmarking it, that's important. The process has to be a two-way conversation. And we do run quite a lot of webinars when what are called check-ins, and we, supporting the teams who are on the front line doing all this work. And this forms a huge part of our activity, and we get a very high level of attendance in the webinars and the other two-way communications that we have with our colleagues in the NHS. We also produce patient resources, because it's not just the clinicians who need that kind of support. At the end of the day, this is for patients, isn't it? Sometimes we have found that the methodology sometimes is not properly applied, and therefore we have come up with the quality improvement support. And anyone who wants to access this, it's freely available to download on our website. And these improvement registries, repositories, and workbooks are a good way for people to get initiated in the process of quality improvement, which then drives healthcare improvement. And as I said before, we do provide all the research and publication support, and I'll highlight a few things in the coming slides. So just collecting data is not a function. We do take it towards supporting the frontline teams and our patients in making those changes from clinical data to outcomes. Next slide, please. So just a summary of a few specific things around individual audits. One of the things where outcomes have significantly improved within the hip fracture care is the halving of death rates. So that is a phenomenal achievement, and it's probably one of the best, if I can say, in the world. And again, of late, we have been focusing on improving the secondary fracture prevention measures, after hip fracture has occurred, and that has really gone up to about 61%, again, probably the highest in the world again. When it comes to fracture liaison service database, we have started looking at or focusing on spinal fractures, which are high-risk fractures, and improving the entire care process for the patients through that pathway. And again, we have pioneered through the National Audit on Inpatient Falls an optimized approach for managing people who have fallen, and kind of changing the culture from not just preventing a fall, but also how do you encourage safe activity after a fall. So these are some of the highlights that I have picked up from individual audit programs. Next slide, please. But on a broader scale, there are quite a lot of things that the outcomes, that have been produced through the audits, we are quite proud of. So as I said earlier, a lot of it is around patient benefit, but we also focus on quality and safety. I think we are focusing more and more now on equity of care, because there are some fractures which we have not really given attention to, but for a patient, it makes a huge difference when they are not treated at par as with other fractures. So I think that is equally important. I think we also collaborate with our colleagues, not just at a frontline level, but also from an organizational point of view. So GIRFT and other organizations do work closely with us. And we also produce toolkits which help service improvement happen. And as I said earlier, the knowledge exchange, the QI training are all initiatives that we have taken very seriously. Next slide, please. So from what the audit is all about and how does it fit into the reality of the three shifts that we have been talking about quite recently. Next slide, please. So if we look at each one of them, from sickness to prevention, we're already doing a lot of it in terms of secondary fracture prevention. And as I said, in terms of equity, we want to cover all fragility fractures through this pathway. But where we really want to work on going forward, and these are ambitions, next slide, please, is actually primary prevention, which is reducing the risk of that initial fracture. And for this, a lot of things have to change. And as Sally alluded to earlier, we probably need to look at how policy will help implement the ambition that we have. So, for example, identifying high-risk individuals before they fracture, embedding, bone treatment. It's a broader, it's not just about medicine, but embedding that as a part of business as usual, and to take care of mitigating circumstances which may lead to people being at high risk. And for that, what needs to happen is the pathway emphasis rather than process and process point emphasis has to change. We will need more collaborative working with primary care, and we shouldn't be working within silos of primary, community, or secondary care. And as nowadays we know, data is king. Data sharing is as important as anything else for this to become a reality. So sickness to prevention, definitely our ambition. Next slide, please. Analog to digital, again, there are certain things which the government has come up, as they call it, the bricks to clicks, single patient records. All the things that you see on the left are really great ideas, but for it to be implemented, and obviously that's our ambition as well, we just need a lot of good quality data in the first place, but also systems in place where data sharing becomes a lot easier. I think where we would like to go would be what's called precision health, which is a combination of population health and precision medicine. And what that means is, especially in terms of osteoporosis and fragility fractures, you can do targeted risk assessments, and identifying cohorts of people who are at high risk. What I would really like to see is, while these audits are at the moment very clinician facing, I would really like to see a much more patient facing audit portal, and that's where the NHS app and the others which the government is proposing will definitely help. And I saw a question earlier about PROMs, and there was a question around PREMs as well. I think both these measures need to be built in for us to really improve outcomes for patients, and I think that's our second ambition as far as the analog to digital goes. Next slide, please. and from hospital to community. So if you just have a think about, I have added up how much time a patient with a fracture actually spends within a secondary care environment, and that's only about 0.1%. 99.9 and give or take a percentage is spent in the community or or within their own homes. And I think when we develop these systems or audit programs, we really need to bear this in mind. So from an operational point of view, is it not possible for a lot of the audits to operate within the community, and as not just the services, the data also needs to flow seamlessly from hospital to community. And I think these are points that we need to ponder if we are going to make the three shifts a reality. Next slide, please. So having said all this, I think going back to what we are doing now, and this is more of a plea for people who actually actively engage with the audit, it's using the existing data from the dashboard, as Sally said earlier. What we find is people go off and do a lot of data gathering within their own trusts or work environments when the data is easily available on the clinical audit platforms, not just ours, but all the other clinical platforms. That itself saves a lot of time. And the methodology should be to identify the areas of improvement that makes a meaningful difference to patient, and therefore involve patients and carers in anything that you do. That sets a huge, it makes a huge difference to how we then reconfigure services, because it has to benefit patients rather than it working around how clinicians feel it should. And always try and wherever possible stick to a methodology, because what you don't want is to for all the work that you have done to not be sustainable in the long term. So I think that's an important principle to apply. As an audit program, we are there for support, and any advice that you would require is provided by us. We're more than happy to do that. And at the end of the day, the teamwork is what delivers change. And going back to where we started off, how does clinical audit improve outcomes? This is what it does in the present day, but we also have the ambition to make it even better for our patients. I think that's the last slide, Ian. Thank you. And I'd really like to acknowledge the guidance that we get through our advisory group from patients and carers and our selfless colleagues who make this audit program a reality. Thank you.
Thank you, Sunil. I see you're getting a virtual round of applause on the screen, richly deserved. I'll certainly make a couple of comments of things that struck me. Speaking as someone who has family members affected by osteoporosis and fracture, it really brings home the importance of this work. I think there's some really striking things within your presentation. Really liked how you showed the average increase in performance over several years across the whole kind of population of data. I thought that was really kind of an impactful way to show data. And I think there are some really, really excellent segues of how audit data, and particularly from this audit, could feed into the strategic commissioning framework, with helping understand the current context, helping to develop population health strategy, and helping to evidence impact. And of course, this is just one of many audits that are out there. I guess the challenge for strategic commissioners is how do they best integrate the data that's available to them, not just from this audit, but from multiple audits, trying to do other powerful things. I'm going to say, Lacey, have we got time for a question? And is there a burning question there for Sunil in the Q&A? And folks might be getting their typing fingers warmed up to ask Sunil questions after that powerhouse walkthrough of the falls and fragility fracture audit that he has just shared with us. Is there a question there, Lacey, that we can address?
There is. I'll start with one that's very fall specific. And Esther has asked, given that women are disproportionately affected by osteoporosis and fragility fractures, was menopausal status and history of HRT use collected as part of the audit data?
Yeah, so very good question. And these are things that at the moment we are not specifically collecting. We do collect data on the medications that are used within the FLS or the Fracture Liaison Service database questions. But this, along with a few other specific medications and processes, are slowly, as we get feedback, we tend to add this on to the audit data collection. I think we also have to be mindful to balance the amount of data being asked to be inputted by the teams. So, we don't want the data burden to go up significantly. So I think the answer is at the moment we are not specifically looking at HRT as a key performance indicator, but some of that data is being pulled through. Yes, thank you.
Okay, I think maybe can we take one more question, Lacia, and then we'll press on in the interest of time. Thank you.
I'm going to paraphrase on a question earlier posted by Sarah Chessel, and it's because you, Sunil, mentioned sustainability, and she talks about bringing patients involved and sustainability of the work that you do. And I think in general, it would be good to hear from you a bit more about the steps that you take to ensure sustainability and patient involvement in the work that you're doing.
Yeah, thank you. So I think if you have 5 or 10 clinicians sitting in a room and ask them to solve an issue, you will get a certain set of responses. You add one patient or one patient carer into that group, the solution becomes very patient focused, or the needs focused. So I think whatever we do, we have a patient representative, a carer representative, all the 3 audits. And in our board as well, we have patients sitting on giving us those kind of insights into what actually works for them. And that is where I think that's one of our big strengths. And many of the outcomes that you see that have, or the key performance indicators that you see are based on the responses or the guidance that patients have given us, even to an extent that when we do our training when we have our webinars and trainings for our frontline colleagues, we do include a patient's voice in there, because that is what is key to any decisions that we make.
Okay, thank you, Sunil. I think last chance for virtual round of applause to show your appreciation to Sunil before we move on. It's still coming in, Sunil. Like what you had to say, and quite rightly so. Many thanks for your contributions this morning. Well worth it, I think. And again, an excellent contribution to today's first session of Clinical Audit Awareness Week. I think we can tell from this. Thank you. Cheers, Sunil. I think you can tell from the screen, folks, that we've got our next week, which is me in a strange turn of events that the host has to introduce themselves, which I'll do now. So, as I said, I'm Ian Smith. I still am Ian Smith. I have over 25 years of experience within the NHS. I've worked as both a professional analyst and a professional improver, and I've applied and supported others to apply improvement methods in various healthcare contexts at local, regional and national scale. I've got quite a lot of experience in learning design and pedagogy. I've worked on national capability programs using both traditional face-to-face and technology enhanced learning formats. I am also a maths graduate. Please don't hold that against me. And I have postgrad qualifications in research methods and transformational change, as well as a PhD in healthcare quality improvement. I do some visiting academic work, and I'm an associate editor with BMJ Leader Journal. But enough about me. Let's thank you for the round of applause there. Let's talk about the Association for Clinical Audit Registries and Quality Improvement. If you could move us on slide, Claire, that would be super. So what are we doing? Well, first of all, there's an association for everything. I've been kind of looking into associations and what they do, and there seems to be one for any topic that you care to think of, except not for us in the audit outcomes and registry world. And given the importance of clinical audit and registries and the contribution they can make, and what we've heard from Sally and Sunil this morning, that seems like a gap. And so to address that gap, we're looking to build a national home for audit, registry and outcomes data professionals. And this idea, the Association of Clinical Audit Registries and Quality Improvement, or ACAR-QI, or probably just ACAR as we might call it because it's a little bit easier to say, it aims to be a new member-led association for professionals involved in clinical audit, registry and data-driven quality improvement. Over the last few months, we've been trying to lay some of the foundations for ACAR, and yes, the photograph on the screen on the right there does depict a fairly grand building, and we would like to build something significant and meaningful. And we know that even the biggest of buildings start with foundations, and that is where we're starting. And if we can move to the next slide, please, Claire. So why are we doing it? Well, first of all, clinical audit, registry and outcomes data, they are considered essential components of a well-functioning healthcare system. There's also this growing importance and remit for using data in the design, delivery and ongoing improvement of care. We've talked about it a little bit this morning around the new strategic commissioning framework. Sally's given us a lot to think about in how audit data can be used to influence policy, and Sunil's given us great examples of what that can look like and what the impact can be at the front line. But we do, it feels, sometimes have a bit of a somewhat fragmented and under-supported community. So there's an opportunity perhaps to come together to increase member. Have we moved on one? Could we move just back a second on the slides? Thank you. Perfect. There's maybe an opportunity to come together and increase momentum, our overall credibility and impact. There's also a significant emphasis placed on audit and registries within the 10-year plan and other recent reviews. For example, audit and audit data and outcome data, specifically referenced in the 10-year plan, page 87 to 88, if you want to look that up. And other recent outputs like the DASH review have highlighted the need to make that data more available, more accessible, and as Sally put it, more transparent. So there's quite a lot of emphasis in the policy landscape on what audit can do. If we can move on one slide, please. Perfect. So what could this look like? Well, in creating a national home for audit, registry and outcome professionals, we'd like to think of it that ACAR can act as a national voice and advocate for those of us improving care through audit, registry and outcome data, and to promote the efforts to drive improvement in patient impact. We're very keen to bring the community together to connect and learn from itself, as well as to use our collective voice to influence national direction and raise the profile of audit, registry and outcome data and the impact that it can have, and effectively want to support that community to connect and learn and use its collective voice for positive influence. And as I say, I think we've had a great introduction to why that might be a powerful and useful thing to do from the presentations from prior speakers this morning. So if we can move on one more slide, please. So who's this for? Well, effectively, if you work with data that improves care, this is for you, we think. Whether you're a clinical or non-clinical audit professional, whether you're an audit or registry provider, or a quality improvement professional using audit and registry data to drive improvement, we're keen to bring the community together to raise the profile and impact of our work. And again, if we could move on one slide. Excellent. So what have we been doing? We've been thinking about what's the initial direction and how can we start laying those foundations and how can we kind of move this forward. So the initial strategy for developing ACAR is focused on first establishing some initial governance and then three main areas, that being engaging the audit and registry community, training and continuing professional development, and thought leadership, influence and advocacy. So we'll say a little bit more about each of these things. And again, if we can move forward one slide, please. So first of all, thinking about governance establishment. An initial step in creating this to support the early shape and development of ACAR is to recruit a credible chairperson. I mean, the chair will have a key leadership and influencing role. There'll be a figurehead for the emerging association. And this is something that we have been working on over the past few months. Various candidates have been kind of brainstormed, and we've made some approaches to people proposed as potential chairs and steering group members. We have had some positive feedback when we've made approaches to see what the interest is in being our inaugural chair. We're not yet, I'm afraid, in a position to make any announcements today, We are getting closer to putting the right person in place, and we're optimistic that we'll be able to share some more about that in the near future, and about an initial steering group and governance structure. So more to come, hopefully in the near future. Again, if we could move forward one slide, please. In terms of engagement, I think it's important for us to engage the clinical audit and registry community. Obviously, we are doing a lot of that this week in Clinical Audit Awareness Week. I think it's important for us to socialise the idea of ACAR. Since starting this position late last year, I've reached somewhere around 200 plus individuals to raise the idea of ACAR. That does sound a lot. There are more of you on the call today, so if that's not you, please be aware we're still continuing to try and do that. Certainly I've been involved in presentations, conversations with various individuals and networks. There is still more to do, and one of the things that we've trying to do to help this is we've recently established a collaborative workspace on the Futures platform. We're looking forward to launching this soon, hopefully in the coming few weeks, and starting to invite colleagues to join us on that community forum to start building the ACAR network. And one more slide, please. So in terms of influence and advocacy for the sector, we've started some early activity in this space with the publication of sector advocacy blogs. We've had a first one in BMJ Leader Journal a little earlier this year, a couple of months back. That blog focused on quality management and how clinical audit data can interface with quality improvement to drive impact for patients. That blog's now been viewed over 1,000 times, maybe more, as of today. It certainly attracted attention on social media via HQIP's channels and those of others, and we will be looking to develop further pieces and publish more content raising the profile of audit and registry work and how they contribute to QI. Hopefully some of that might be community driven. I'm certainly talking to a few individuals who are interested in writing blogs, and some of it will be us trying to advocate for different aspects of the audit registry and outcomes community. We've also been taking forward some work initiated by HQIP on the issue of resident doctor involvement in audit and improvement. We've had some helpful conversations with colleagues at several Royal Colleges and the General Medical Council relating to the requirements of CPD and specialist training recruitment and how that can influence resident doctor behaviour around quality improvement. That message seems to have been quite well received, and we have been asked to get involved in some joint work led by NHS England and the Royal Colleges in a working group around this particular issue. And we're also holding our own roundtable with Royal College colleagues later this afternoon as part of Clinical Audit Awareness Week. And one more slide, please, Claire, if you will. And finally, we're really keen to support clinical audit and registries colleagues with continuing professional development, including skills for improvement to maximise the impact that the community can have on quality, safety and effectiveness. And I think Sunil's given us a really great example of how audit data can drive improvement and how quality improvement skills can be used to take forward some of the outputs and outcomes of audit and registry and outcome data. So we're very keen on seeing what we can do to step into that space. A lot of that we would like to think can be driven by the community itself, sharing with us what will be most helpful and where we can concentrate useful effort. So I think I'm happy to pause at this space. Thank you, Claire. Well anticipated there. Many thanks for listening. I think we may have a time for a few questions. I think Sally has had to leave us. I think Sunil is still on the call, so in taking questions we might be able to take some questions for Sunil. I'm happy to take a few questions as well. I really appreciate the little bit of virtual applause. It's very gratefully received. Many thanks. And then I'll just go across to Lacia, my colleague, to see what have we got coming up in the Q&A box. Happy for you to direct questions to me or if there are any, but also we can take a few more for Sunil on the general topic or specific to falls and fractures, depending what is there.
So an easy starter for 10 for you, Ian, I think.
I hope so.
So this is from Tanesh. So brilliant news about ACAR. Will there be a minimum competencies or entry requirements for clinical audit professionals to take membership?
It's a super question. We're not ruling anything in or out at the moment. We're trying to socialize the idea and get some practical things in place. So at the moment, we're focusing on trying to help the community connect, trying to help the community learn from itself, and trying to influence, particularly around some of those big issues, the likes of which that we've mentioned here, and the likes of which that Sally and Sunil have talked about at the moment. I think the question that you raise around kind of competency and capability is a really interesting one for us. We're certainly keen to help develop competency and capability in the space. And if members or emerging members highlight this as an issue, that's something we collectively could work on, then that's the way we'd like to operate, to take forward kind of member-led ideas where there's a groundswell of wanting to do it. I think I've just seen a message come in separately from a colleague who I've been kind of given some thoughts on them trying to write a blog, and they're actually trying to write a blog in this space about what should we do around skills in the community. So I say we've got maybe some stuff coming out shortly to prompt a little bit more around the conversation and discussion. And if it is something that matters to the wider community, then I think it probably will be something we take to our new steering group when it's emerged, and see if we can set up a bit of community-led work around it. What else do we have, Lacia?
Okay, so the next question
Please do keep them with not being too difficult for me as well. That would be very, very grateful for that.
So the next question is from Claire, and she says that they'd welcome a position statement supporting resident doctors. And is it part of the wider support for resident doctors undertaking audit and QI?
Yes, we do have a position statement on resident doctors and QI and audit, which is, I'm not sure if it's published yet on our website, but it has been shared with numerous Royal College colleagues. The message has been well received. The position statement itself was developed based on work that a resident doctor acting as a fellow for HQIP did the work on putting that together to kind of highlight what that experience was like, and how some of the policies kind of drove behaviour, some helpful, some less so. So that kind of is out there. It is getting a bit of traction. There are a few other papers that have been published recently talking about this issue. And as I say, we've been invited into a joint Royal College piece of work, which is beyond just resident doctors. It's looking at kind of across all clinicians, the education curriculum around particularly quality improvement and what the requirements of those colleagues is. So I think it is an emerging space. If our position statement's not yet out publicly on our website, I know that we're keen to do that, and I'm sure Lacia and colleagues will be looking at getting that out soon. I know that our comms colleagues have been a touch busy in the run-up to Clinical Audit Awareness Week that is now here. So hopefully when we get through this week, all of the outputs from this week and some of those other things, we will have content to share with people in the near future.
So actually, there's just a few final touches being made internally there. So we hope to have it up this week. Do take a look at our website.
Hot off the press. It's coming very, very soon. And I don't suppose, and you got a round of applause for it as well there, Lizzie. I don't suppose you've got a question for Sunil amongst your questions.
So I do, and I'm going to bring one in that sort of almost brings both of you in, which is around how ACAR, QI, and the audits can work together, and how you can learn from each other, how you can support each other, how will you collaborate on the work that you're doing? Excellent.
Sunil, do you want to take that in the first instance?
Yep. So I think the important thing to learn is, there may be multiple audits, running, but I think what all audits fundamentally do are the same thing. They collect data relevant to that domain. And I think how we bring about improvement based on the data that we have is based on certain principles. And I think where the ACAR can really come in is for us to share good practice, because every audit does certain things slightly differently, but we can still learn. So, for example, Ian, you mentioned the roundtable this afternoon. I'm presenting something around how we support resident doctors in their in their QI journey. So I think there will be other audits which have tackled difficult situations or problems in a different way. And I think that's that platform where we speak to each other. That's what probably ACAR would help out with. Thank you.
Thank you, Sunil. Yeah, I agree with what Sunil's said there, Lacia. Yeah, audits do tackle quality improvement in slightly different ways, and yeah, I think ACAR offers an opportunity around connecting the community to itself and hopefully facilitating different audits, different audit providers, and different colleagues learning from each other. I think everybody's got something to offer. Everyone that I've spoken to in the audit and registry space has really interesting stories to tell. Every conversation's left me kind of enthused and with something to think about. So I think the more that we can harness the collective knowledge, experience, and wisdom that there is, and allow more people to benefit from that, I think the better. I think Sunil's really summed it up really very, very neatly for us. Then we take another question, and I think we might move in to kind of wrapping up and advertising what comes next across the rest of Clinical Audit Awareness Week. Do you have a question for us, Lacia?
So there's quite a few questions coming in around membership and fees and keeping ACAR affordable.
Yes.
You may not have all of this worked out yet. I understand that part of what you're doing is working with the community to understand what ACAR will be. But I wonder if there's anything you can say about how available and how affordable ACAR will be.
Yeah, I'm quite mindful of it. I think what we've got a very broad community, lots of different types of players, if you like, within that community, and trying to bring it together in a way that is accessible for as many as possible is very important. Hence this focus on connect, kind of learn and influence as an early stage activity to kind of introduce us and put us on the map, if you will. We do have to think about for the longer term what kind of approach, structure, business model, fund generation can work. But yeah, I am mindful of the affordability angle. There has been kind of past exploration of what kind of payment structures and member structures might be most effective. I think that needs more thought and more engagement with the community to understand from the different players' perspectives what the individual benefits and practicalities might be. But I think it's important that people are thinking about it and raising questions. And I think it's important that we're hearing people's concerns about wanting to be part of it, but also in an unaffordable way. So we've not made strict decisions as yet on how to do it. We've got numerous ideas. Some of them colleagues are talking about on here. But I think we want to, as I say, get our initial steering group and governance in place, hopefully coming very soon, and then start to engage more with the community. I think hopefully on the back of today and this week, where we're starting to kind of talk a lot more about what ACAR is trying to achieve and come up with different approaches, maybe a combination of approaches of raising funds, again, within our overall not-for-profit and charitable status, to build something that works for as many members as possible. Okay, unless there is anything to add from yourself, Lacia, shall we sort of start to move into the wrap-up part of the session? I don't want to delay anyone coming up to 12 noon. I think we're a few minutes ahead, but you'll notice we've got on the screen here some information about what's coming up this week. We've come to basically the end of our presenter session this morning. Many thanks to the speakers, I think Sally and Sunil, who've got us off to, I think, an excellent start for Clinical Audit Awareness Week 2026. And also many thanks to you all for taking part in today's session and coming along and getting involved with Clinical Audit Awareness Week. You're really the people that are helping to make it the success that it is, and no doubt will be across the rest of the 5 days this week. Don't forget, though, that there is still plenty to look forward to across the rest of the week. Details of the sessions are there on the screen, including tomorrow's theme on patient involvement and care equity, and indeed Wednesday's session, Shaping the Future Together, which will open with the NHS Chief Executive, Sir Jim Mackey, at 10 o'clock on Wednesday morning. Don't forget, we've got the first of our awards, Clinical Audit Awareness and Excellence Awards, I think at 12:45 today. All of the sessions can be registered by using either the QR code on the left of the screen and the link next to it on the HQIP website. All the information there for you. Grab it while you can, or get your QR code up on the screen. You can register for all of those there. We hope that you will join us again throughout the week and register for further sessions. And if we can move on one more slide. And finally, the last one. We really would like to get your feedback, not just on this session, but all of the sessions through the week. So please do complete the short form if you can by scanning the QR code or accessing the form via the Clinical Audit Awareness Week page on our website. And that's it, folks. A final thank you from us, and we do hope that we will see you all again with us on sessions this week and beyond. Many thanks, folks, for getting us off to a great start for Clinical Audit Awareness Week 2026. Thank you.